Okay, good evening, everybody. Thank you so much for joining us for this third webinar series from the Stillbirth CRE. And it's marvellous to see close to 200 of you already at 17:03. So I'm just going to talk through a little bit about what we're going to do today and who we're going to hear from, and a little bit of housekeeping before we go into the webinar. So importantly, particularly for this webinar this evening, is that we are aware there might well be parents who've had recent or not as recent loss online tonight. And if people feel that after the webinar they would like extra support, this is the details for SANS, Red Nose and Bears of Hope. In terms of websites and in terms of telephone support. And we really appreciate any parents who have joined us tonight. Thank you so much. So today I'm co-chairing with Anne-Marie Imrie, who you're going to hear from shortly. Anne-Marie is a social worker. She is a bereaved parent, having had a stillbirth that you're going to hear about. She's a wonderful woman, currently pregnant and working well during her pregnancy, helping us out from the CRE perspective here tonight, and is the consumer representative on the New South Wales Clinical Excellence Commission Safer Baby Working Party. I'm Adrian Gordon. I'm a clinical academic in neonatology, and I'm particularly passionate about bereavement care and prevention of stillbirth. So before we start, I would like to respectfully acknowledge the traditional owners of the land and sea on which this event is taking place. I also acknowledge elders, both past and present, and that their cultural and heritage beliefs are still as important to them today. I also recognise those whose ongoing effort to protect and promote Aboriginal and Torres Strait Islander cultures will leave a lasting legacy for future elders and leaders. So again, welcome. Last year we held the first ever annual Stillbirth Forum in Brisbane, and that was a wonderful couple of days with over 250 attendees. At these webinars, we've had at least 200, and there's already 205 of you here tonight. And we have moved to this obviously because of a certain virus, and we're very happy to be able to update our partners, clinicians and parents with the latest information through this series. We hope that if this is the first one you've joined, you might join the last one and sign up to that one also. There will be a short survey so that we know whether these have been useful. These are the webinars that we've had so far. We've heard about the Safer Baby Bundle and challenges and opportunities in its delivery during COVID-19. We've heard about the great work of the COVID task force and its relationship to pregnancy and perinatal care. And today we're going to hear about bereavement care during COVID-19. So before we begin, just to let you know a couple of housekeeping things. We will be recording all of these webinars, so all those that sign up will be able to access these at the end of the series. Please submit your questions anytime. We'll do a formal Q&A after each of the talks today, but we'll also do a Q&A to both of our speakers at the very end of the presentation, and we'd love you to complete that exit survey if you can, please. You can either put your questions in the chat or you can put them in the Q&A section. We'll monitor both. So now it's my great pleasure to introduce Anne-Marie, who's going to in turn introduce you to our speakers today.
My name is Anne-Marie Catherine Imrie, also known as Annie M, Annie, Buffhead, Porky Bits, Fat Stuff, Moonface, Mummy, Babe, and Anakin Skywalker. All of these names have been given and received over the years with much affection. But there's one name that was bestowed upon me in January 2015 that initially I did not receive with affection. Bereaved mother. And that's due to the meaning I placed on it. To me, bereaved mother meant failure. I had let myself down. I had let my husband down. And most of all, I had let our baby down. And that's what I want to talk to you about. The meaning we make from our experiences. As care providers, you are gifted an opportunity to help shape the meaning a bereaved parent places on their experience of baby loss. You are seeing these parents at their most vulnerable, whether they have just found out their baby died, whether you are helping them birth that baby, or whether you are seeing them in subsequent pregnancies. How you respond emotionally matters. I remember when I told my husband that I was pregnant with our very first baby. I remember exactly where I was standing on a city street outside the doctor's office, and I called him to say the test was positive. And his response was, "Oh my God, we're pregnant?" He said, "We're pregnant." And I know it might sound small, but the meaning I took from his choice of language is that he's in this with me, that we're in this pregnancy together. And man, was that togetherness needed just 6.5 months down the track when we found ourselves in a hospital room hearing those soul-crushing words, "I'm sorry, there's no heartbeat." Our son Xavier Rocket was stillborn on the 31st of January 2015. He was warm to hold and sweet to smell. His eyes were gently closed and he was gorgeous, but he was gone. When he first died, the meaning I made from it was this: the universe hates me. I'd obviously been a terrible person in a past life and now I'm being punished. Or maybe I'd been a terrible person in this life. I started going back through it, analysing it with a fine-tooth comb. I even went all the way back to primary school in year 5 when my friend told me to tell our other friend that she couldn't play with us anymore. And so I did. This theory kind of made sense to me, so I took it to my counsellor, embarrassingly, and she just looked at me and said, "I'm sorry, what? What happened in year 5? I'm confused." She hadn't made the connection that I had made. And that's actually a really good example of how we can go so wrong in the relationships with the people that we love. Because we're going around with stories in our minds about why things are happening, and the people we love have their own stories. And if we don't have compassion from one another, it's very rare that the two marry up and things can just turn into a big old mess. So anyway, back to the universe hating me. I stuck with this story for a really long time. And because the universe hated me, I hated it right back. It was a really dark place to be. But there was a glimmer in my heart, and that was the discovery of a soulful relationship with my son. The realization that my bond with him continues even though he's not here in physical form. It was that realization that led to my ritual of reading children's picture books to Xavier at the cemetery, and ultimately the creation of my book, You Could Have Been. But even with this newfound realization, I was still holding on to anger and resentment. Even after the arrival of our rainbow baby Kai, I still raged against reality. I said to myself, Xavier should be here with Kai. He never should have died. This isn't right. It's not fair. We're missing out. And all of that is true. But it doesn't bring him back. The reality is he's gone. And I realized that if I continued to rage against that reality, that I would be setting myself up for a lifetime of suffering. I realized as the dark clouds of grief slowly began to part, that in order to reduce suffering, I needed to accept what is. Not be happy about it, but accept it. I also realized, and just bear with me here because this is a little bit out there, but I also realized that if Xavier had have somehow come to me before I was pregnant with him and said, I can only stay for a really short time, will you be my mum anyway? My answer would be yes, every time. And so I began to make peace. I began to accept what is. And just to be clear, peace has not come from the generation of positive emotions about my son's death. It still hurts. Rather, peace has come from the dissipation of toxic emotions about it. There's a difference between pain and suffering. Pain comes as a direct result of the event. Grief, sadness, heartache. Suffering comes from the meaning we place on that pain. The universe hates me. This is all my fault. I'm not good enough. And so why am I telling you all of this? Because your life story might be different to mine, but we are all trying to make our lives mean something. We don't get to choose the events that happen to us, but we do get to choose the meaning that we make from them. I eventually learned that the universe was not punishing me. That's not how the universe works. Things just happen. There is abundance and drought, career and unemployment, partnership and separation, life and death. And none of us get immunity. No one on this webinar has had a pain-free existence. And if you have, keep that shit to yourself. Nobody wants to hear about your happy life, especially here in Australia. We're like the underdog, the one that's been down through the trenches and clawed their way out the other side. I know as care providers, it is your role to provide the best practical and medical care that you can. But as I said earlier, you also have an opportunity to get down in those emotional trenches with bereaved parents and meet them where they are. If you feel like you've got this wrong in the past, it's not your fault. Western society does not have good enough language around grief. If I can offer you some words that are good enough, it would be these. Look up at your patient and say, I am so sorry about your baby. Did you choose to name them? If they answer yes and tell you the name, you simply say, that's a beautiful name. I know this is hard. I'm here for you. They chose not to name their baby. Simply say, okay, I know this is hard. I'm here for you. 30 seconds is all this takes. 30 seconds and you can transform an interaction you have with a bereaved parent. Because in that 30 seconds, you have gifted them this. My baby matters. I matter. And if you were to ask me what the term bereaved mother means to me now, I would no longer say failure. I would say strength, connection, and love. Thank you for being here. Thank you for caring. And thank you for your passion. We are now going to shift gears quite quickly and move across to Fran Boyle's presentation. So I would just like to introduce her. So Fran is a social scientist and health services researcher with qualifications in psychology and public health. Fran co-leads the Stillbirth CRE's Care After Stillbirth program of research and is deeply committed to improving outcomes for women and families through the implementation and evaluation of best practice, parent-centred perinatal bereavement care in hospital and community settings. So welcome, Fran.
Thank you so much, Anne-Marie, for your beautiful, powerful words, for setting the scene to this afternoon's webinar so beautifully. And I'm very sorry for your loss. I've subtitled this presentation, Delivering Bereavement Care at a Distance, because that's exactly what's happening in so many places, and it can be incredibly challenging. I too acknowledge the traditional owners and their custodianship of the lands on which we are all meeting today. In my case, that's in Brisbane, and I acknowledge the Turrbal people, and I pay my respect to their ancestors and their descendants. I'd also like to take a moment to acknowledge the little lives of the many thousands of babies gone too soon. And I share this quote from Emma Gilkison's beautiful book, as I'm sure it resonates with so many of us who've travelled the road of baby loss. So for all who've been touched in some way by pregnancy loss, we acknowledge you. I'm going to start with a little background from some recently published literature that tells us that the COVID pandemic is a significant source of stress. You probably didn't need me to tell you that. But anxiety, depression, and a whole range of other mental health symptoms are higher than usual in the general population. As well as this study by Jane Fisher and colleagues, which is about to be published in the Medical Journal of Australia, global data tells us the same story, as do studies following other major disasters. And notably, some groups in the population are at heightened risk, including those who are already experiencing social disadvantage and other stresses as well. We also know from the literature that the perinatal period, that's the time around birth and soon after, a time of great change at many levels, is also a time when women and their partners may be susceptible to a range of mental health issues. And this too is exacerbated by COVID-related stresses. Recent work from our good colleagues in Italy on the experience of pregnancy during the COVID pandemic tells us a little about the changed experience of pregnancy. And to quote from their paper, while joy and feelings of closeness, safety, serenity and love characterised childbirth expectations before COVID-19, fear, loneliness, anxiety, danger and worry are now dominant. And once again, some groups will be particularly vulnerable. And that most certainly includes parents who've experienced the death of a baby. When a baby dies, we know how important the care they receive is to their immediate and longer term psychosocial well-being. And during these difficult times, best practice perinatal bereavement care is more important than it ever was. But it's a challenging area of practice, always, and especially under pandemic conditions. Care providers may be experiencing their own stress, as well as secondary stress that's exacerbated as they respond to the pandemic. They may become exhausted, overwhelmed, and sometimes feel powerless to help. And it's vital that they're supported. About 18 months ago, we launched the Clinical Practice Guideline for Respectful and Supportive Perinatal Bereavement Care, and this brought together the best available evidence, and it followed extensive consultation with parents, clinicians, researchers and policymakers. As part of that process, we developed a framework that identifies the overarching goals of perinatal bereavement care. And they're the 4 key goals in those circles. These 4 goals of care are interconnected and put together, they form the overall care experience. The 5th goal of the framework relates to the organisational response, and this acknowledges the wider system context in which care takes place and the importance of enabling and supporting care providers to deliver the best possible care in the worst possible circumstances. And the guideline that we've developed contains 49 recommendations that should apply in every maternity setting in Australia. There are 41 recommendations for healthcare professionals and 8 for services. And you can freely access these via the Stillbirth CRE website. Now, an important question for us has been, is COVID-19 undermining bereavement care at a time when we know it's more important than ever? So we recently conducted a survey. We wanted to gain a rapid picture of how COVID restrictions were affecting care and what adaptations were being made to the recommendations that have been identified. And using our Stillbirth CRE networks, we reached out to care providers and others who are actively involved in providing and shaping care in hospital and other settings, including the community and including bereavement support organisations. So this was a survey conducted between late March and mid-April. We had responses from 28 care providers. It was very rapid consultation, and they included clinicians, counsellors, parent support organisations. And what we'd asked each respondent to do was to rate the impact of COVID-19 on each of the recommendations that we'd identified, and to ask them to describe what sorts of adaptations they'd made or that they thought might need to be made. Now, just to give you a brief overview, it was very clear that there were impacts across all the domains of care, and particularly for some groups of parents. Care providers expressed a very high level of concern about the consequences for parents and how they could address them. And it was very evident to us that many healthcare providers had risen to the challenge of implementing best practice perinatal bereavement care in pandemic conditions, and that some of those innovations perhaps should be kept into the future. As one hospital midwife said, 6 months ago, we wouldn't have believed it likely or even possible to be having follow-up meetings with bereaved parents by video conference. Now, I'm just going to move on to drill down a little into some of these points. But before I do that, I just want to note that there is, of course, variation across facilities. And what was an issue in one facility may not necessarily be one in another. So when it came to communication, one of the biggest issues was about wearing masks. Probably not surprising, masks undermine speech, non-verbal communication and expressions of empathy. They essentially disrupt the human connection. And there are particular issues when English is not the primary language and where hearing impairment may be an issue, for example. Masks can also be a trigger for memories about a previous trauma. Some noted how important it was to connect even briefly before donning a mask, if that was possible. Physical distancing also disrupts that human connection. The touch to a hand, as one respondent noted. A hug. These are such powerful forms of grief support in our culture, but suddenly they've been taken away. Physical distancing also has implications both for the people who can be around and for the availability of appropriate physical spaces for communication. Not having space for extended family to gather was something that came up repeatedly, and so did the limited availability of private spaces at times due to changes in the use of wards and other spaces. And providing culturally safe care may be particularly challenging. This was something that was raised quite a lot. Without face-to-face support, and when gatherings of extended family, community and religious and cultural services, and also availability of interpreters is missing, these can be real barriers to providing what we know to be culturally safe care. Just going back to masks for a moment, we've seen some areas of practice innovation in the wider healthcare arena, and various strategies have been explored in the literature, including the use of transparent masks, having a meeting over a video link before an in-person masked consultation occurs, and one that I think is really quite nice, providing handouts to patients with photos, with names and reassuring text like, "Dear friend, you are in the hands of people who care about you and your baby." There's also the PPE portrait project that began some years ago with the Ebola pandemic, and it's again come to prominence. And this is an art intervention to humanise personal protective equipment through PPE portraits. So disposable provider portrait stickers that are affixed to the PPE where patients can see them. And as you can see there, when the portrait photo is taken, clinicians are asked, "What's the smile you wish your patients could see?" Memory making is a critical part of best practice bereavement care. At a time when things seem very much out of control, offering parents opportunities to make decisions and to parent their baby can help parents to reclaim some of that control. We know that creating memories is so important for families and a protective factor for complicated grief. And it really worries me to think about missed opportunities for memory making and parenting activities. Art interventions, so there's that term again, have a particular place in perinatal bereavement care, in particular photography, and services like Heartfelt. And in many settings, these opportunities are currently limited or at times not available at all. And this is a concern that came up a lot. And the other thing that came up was how distressing it can be for care providers when they know they have to deny those opportunities to parents. It really was a source of distress for many. So given potential constraints in hospitals, it may also be helpful to discuss with parents whether spending time at home with their baby may offer more opportunities for making memories. And where possible, healthcare facilities are able to offer access to equipment such as smartphones, tablets, laptops, charging cords, etc., to support contact and also to support memory making. And healthcare services can also try to ensure that they have some of those absolutely vital supplies to assist in memory making, access to coal cots, for example, and cameras, memorial boxes and so forth. Funerals and commemorative rituals have been greatly affected. The need for distancing and restrictions on the number of people who attend commemorative services. And in response to these changes, there've been a range of alternative commemorative rituals suggested and online approaches that enable connections to be made without physical interaction. And I know for certain that some of the parent organisations have really responded very rapidly to assist parents with that kind of information. Shared decision making, we know, is a vital part of perinatal bereavement care, and restricted access to support persons may have real impacts on how that takes place. There may be fewer opportunities for parents to revisit decisions about their baby's care, and there may be less availability of access to cultural support such as religious or pastoral care. So these things can really have important impacts on the kinds of decision making that parents need to engage in, often quite quickly. And one of the things that came up and that you can see from the quotes there is the need to be able to communicate with multiple people in multiple places. So that really does complicate what can already be a complex process. In terms of effective support, we've already noted the availability of face-to-face support, including partners and limitations on numbers of family members, including siblings and other support persons. But we know that social support is such a critical predictor of bereavement outcomes, and the loss of supportive contact can have major implications both in the immediate term and down the track. So it's really important that we're focused on ensuring that parents have that support, even though traditional forms are not necessarily available. There are reduced opportunities for family members to be present, and that includes, right from the time of diagnosis, from the time of breaking bad news, through conversations about decisions, through to the birth, through to meeting the baby, to leaving hospital and beyond. So across that whole spectrum, there are points at which social support is disrupted. And that reduced access to support means that it's even more vital for parents to have access to information about bereavement care, including 24-hour support lines such as that provided by SANS. And that assertive follow-up and ongoing discussion and referral to support options is vital, starting right from that first point of initial diagnosis or initial concern about the baby's well-being. And once again, parent organisations and other agencies have very rapidly adapted their services to provide a wide range of online information and support. And I know that Jackie will talk a little bit more about these shortly. Telehealth is a critical issue. And as I mentioned before, it's something that really has come into its own quite unexpectedly. Follow-up review meetings by telehealth have been a major adaptation. And one midwife in our survey said this has been the most challenging aspect of bereavement care. Others highlighted the real benefits, where for some parents, a telehealth follow-up appointment after leaving hospital might be a way of alleviating their anxiety about returning to the hospital setting, and it might also give them a sense of greater control being in their own environment. However, the critical thing is that it needs to be done well, and this means that we need to have appropriate and effective support for staff and parents. And I think this is something that we really do need to work on evaluating. How do we do it well? Is it something that we need to strengthen and make sure is an option for all parents going into the future? And in evaluating these new methods of communication, we absolutely must ensure migrant and refugee women, and we must include the staff involved as well in evaluating their experiences. Finally, in relation to organisational responses, we know that training of staff has been largely suspended. I put just a reminder that we do have our Improve program, which is available online. So we have been able to make that available through an online platform. That's the Improving Perinatal Mortality Review and Outcomes via Education. Remembrance services that are led by hospitals and other organisations have also been suspended. And these are important rituals, important ways of supporting parents and staff as well. And there's a need to rethink how some of these might take place. We know that healthcare providers are profoundly affected and are at even greater risk of experiencing stress in the context of COVID. And there's also that potential for, a sense of failure in professional work due to the reduced options for parents, and that concern about not being able to provide their usual high quality practice and needing to rapidly alter practice. So peer mentoring and support and professional supervision is vitally important. Finding alternative approaches to staff education, meetings and mentoring, for example, using online platforms, is again something that I know has been put in place in some settings, and opportunities to evaluate that and strengthen that exist. Just one concluding comment from one of our survey respondents, I think sums it up very well. Despite COVID-19, we must continue to provide good bereavement care to all families, and we need to balance the provision of that care with maintaining the necessary safety measures. I think that really sums it up as to where we are. Just in closing, I'd just like to mention our Cocoon Global collaboration. This is a global online survey that's exploring the psychosocial impacts and health service practice changes for pregnant women and partners during COVID. And there's a particular focus on the experiences of parents who've experienced stillbirth or newborn death. And we have, at the moment, 14 countries are involved in that survey. So it's an amazing opportunity for us to look at care practices and their outcomes across the world. And if you would like to know more, there is a link there for you to follow up. Thank you, everyone, and I thank all of the people who are involved in all of the work that we're doing through the Stillbirth CRE, and really great to have your interest in this topic. Thanks so much.
Thank you very much, Fran. So we have one question from Jane Warland, which was about, are you going to publish your rapid survey results? And if so, when?
Hello, Jane. Lovely to hear from you. The answer to the first question, we hope, is an easy one. It's yes. The question of when, as soon as we possibly can. We think it's very important to get this work out there. And I also note, Jane, that you have published a commentary article just very recently regarding subsequent pregnancy in COVID times. And that's not a topic that I had time to go into here, but I note that, that's an extremely important and topical issue.
Up next, we have Jackie Mead, who is a bereaved parent and the CEO of SANS Australia, an organisation delivering nationwide support to bereaved families following pregnancy and infant loss. SANS delivers this much needed support using well-trained and committed volunteers who themselves have experienced the tragedy of losing a much-loved baby. Jackie has worked in the not-for-profit sector for almost 15 years and is passionate about ensuring that the voice of bereaved parents influences research, policy and community views. So welcome, Jackie.
So thank you so much for having me. And the first thing I guess I'd like to do is acknowledge the bereaved parents who are part of our audience today. I see you, and you know, certainly acknowledge the bravery that it takes to come and listen to these things when it can be so triggering for us. And the more that's understood about stillbirth, the better we will all be in advocating for change that we need right across society. You'll see two little feet on this slide, and they're filled with words. The words are collated from posts from our closed Facebook group throughout April, indicating the emotions that parents explained that they were feeling. They're probably not a surprise to very many of us, given the devastation that's associated with losing a baby. But one thing that's become very clear through this COVID-19 times is that whilst the feelings are the same, they've certainly been amplified by the isolation that is being caused by restrictions, whether large, like they are currently in Victoria, or smaller. The other sad thing that's happening is that the isolation is re-triggering for parents whose losses are quite a while ago. So that's actually led to a 20% increase in support requests across both Red Nose and SANS as two of the leading organisations providing support to bereaved parents. The difficulty in that is that there are also resource shortages as the SANS volunteers are trying to homeschool their children, potentially facing losses of their own jobs, dealing with all of the things that are happening in their own worlds. Their capacity to provide additional support has been limited. And so, you know, there are competing needs across this journey. We've also seen increased complexity of the cases that are coming to our organisations. Pre-existing mental health issues are certainly more prominent than ever, and I don't think that that's probably a surprise, and it's something that we know is also occurring across perinatal mental health services. We're seeing parents engage with community support earlier in their grief journey, and this has been a really intriguing situation. We've had more than 500 people attend our Ways to Be Okay forums, which have been an online platform to allow parents to come together and explore some of the issues associated with grief and being a bereaved parent. And it appears that almost 30% of the people that have joined those have been very new in their grief journeys. When we have people that are joining in whose losses are only weeks away, not even months away, that is a substantial change in the way that services have been previously accessed. We're finding also that fathers are engaging with online services in greater numbers than we've ever been able to engage them in services, full stop. And we're not exactly sure why, although one dad did give us an insight and said that when you can just switch the screen off, if you don't like what's going on, it's a bit easier to find the courage to begin. We're also finding that as couples are joining online groups, whilst we may initially find that it's the female or the mother who we're talking to, dad's listening in, and over the course of some of these calls, we're finding that he's engaging and joining in too. So there are certainly things that we're learning throughout this that we need to take advantage of and need to continue to be able to offer. Interestingly, more friends are sticking around, and it may be too soon to say that that is an ongoing trend, but that is certainly something that parents are saying to us at the moment. And finally, we do have a reticence of volunteers to return to face-to-face support groups, but there is a small amount of interest in the community in some states, particularly those that are coming out of this more quickly. So we're going to have to really think about how we move out of COVID times to provide the bereavement support that's so desperately needed in the community. Perhaps the most difficult thing, though, that bereaved parents are expressing to us at the moment is, I guess, what I would refer to as compassion fatigue. Families that are under huge pressures to deal with everything that's being tossed at them at the moment are expecting that the grief journey be put aside for bereaved parents more rapidly than parents are sometimes ready, willing, or able to do. And obviously we don't know yet what the implications are for that in the long run, but it is concerning us that compartmentalising grief or not dealing with it appropriately may lead to complications down the track. Certainly something we're going to have to pay close attention to. SANS was in a very interesting position. In March 2020, just as COVID-19 began, we began to undertake our annual survey. And this survey is something that we've done for a number of years, and it's focused on the SANS bereavement care principles, which tie very closely with the guidelines that Fran was discussing, but they were developed based on parent experiences. And so the voice of the bereaved parent comes through very strongly within them. And what we do is we aim to find out how parents have experienced bereavement care over the course of the last 12 months, but also, throughout wherever their loss occurs. But because of when this survey was released, we actually have 3 months worth of data that relates specifically to bereaved parents in COVID-19 circumstances and their experiences and how they differ from parents whose losses were perhaps in the 9 months before or even longer ago. So I'm going to spend some time to take you through those results because it's an interesting and intriguing situation. First of all, it's helpful to know that 98% of respondents were mothers, and that 233 of those respondents, where there were more than 550, had experienced stillbirth, with another 104 having experienced newborn death. The results that I'm going to show you today are very early in the data analysis, but they relate specifically to people whose most recent loss was stillbirth or newborn death. So first of all, we asked people, I guess, a summary question, which was your care supportive, acknowledging your grief and providing you with help? And I guess the results are quite good. I'm just going to reduce so that I can see the slides. Sorry, just 1 second. So the overall results are excellent, having shown a positive response increase from 77% to 93%. So people are saying that during the COVID-19 time, they have received, or more people received, the quality of care that they considered to be supportive than previously. Now, there could be a number of reasons for this, and unfortunately we don't know exactly why that is. We certainly know that there's a recency effect. This comes through anecdotally in a lot of the work that we do. Where midwives and obstetricians have been so closely associated with a very deeply personal experience, in the early days, unless there has been, issues around medical malpractice, most parents are very protective of their midwives in particular, but also their obstetricians. And so they generally talk more positively about them earlier than they do when they've had a little more time to reflect. We also don't know if it's a case of any little bit of kindness in very difficult circumstances carrying additional weight. But as it stands, the results are quite intriguing. You'll see a quote down there. A lot of the positive comments around care for our situation came down to one midwife. If she hadn't been our midwife, I don't know that our experience would have been what it was. And that comes through, again, very, very clearly that a lot of these results that I'm going to discuss with you come down to a single individual. And whilst we need to make systemic changes to support bereaved parents, I think that that is a really important thing for us to understand, as that every health professional can make a significant difference in the lives of a bereaved parent. When we asked about individualised care, the result was also extremely positive. Which again we were quite surprised about. One bereaved parent who I've spoken to recently talked about feeling incredibly overwhelmed as they were trying to arrange a funeral for their baby. They were trying to do it while they were still in hospital. Mum and Dad had both sets of grandparents on the phone and were completely overwhelmed with what was going on. Midwife came in and she actually took the phone off the parents and said that she needed to cut it short, but that the family would call back later. And she then spent some time with that couple talking to them about their needs and what they wanted. And the family described it, or the parents described it as this giving them the time to really think through what they needed to do. And the parents described the fact that their culture was one where they were supposed to show respect for the parents, where the parents' views should be their views, and they weren't, and that was providing them, you know, a whole lot of angst and difficulty. So that midwife, in taking that time and asking what the parents want and really individualising that care, was something that was incredibly important, but it was done in a way that took into account that cultural belief that they held, that respect for their parents was tantamount to whatever decision they made. On a less positive note is the fact that we still operate in a very white Anglo-Saxon approach to thinking about individualised care. And the quote that you can see listed there certainly indicates that. Many people who are offering supports and bereavement care in hospitals understand, you know, the process and what needs to go through, what needs to be achieved. But if your faith doesn't sit in line with that, then even being asked those questions in a repeated way indicates that people haven't taken the time to read through the file and provide the individualised care that you so desperately need. So whilst we can see that things from this survey perspective have improved, it's important that we can keep that, I guess, at that level, because it is so critical. The next question that we asked was, were your wishes for your baby understood and respected when they died? This sits very closely, I think, with shared decision making. So often what we want to do is reduce the burden on the parents to make it easier for them. And I don't think that necessarily means that we understand how important it is to have some control when there has been so little of it in the surrounding experience of losing a baby. So this family included in the survey results that they told this story. I felt so out of control. The only thing I was holding on to was that I'd planned my baby's funeral. They then told me they'd placed a teddy in the coffin, and it sounded like such a nice gesture, but to me, it just made me feel like I'd lost control of that tiny thing too. I pause there because I think that it was a gesture that came from a good place. But when we take the responsibilities away from families, then we can undo the good that we were hoping to achieve. Next, we asked about communication. And this one has been so tricky with masks being so heavily involved in the care for bereaved families. And Fran talked a little about the impact that masks have had and how health professionals feel about them. One bereaved parent told us that the lack of touch and the masks was having a huge impact on her until a midwife came in and told her and showed her the symbol for a hug, for giving a hug in Auslan, which is very simple and very straightforward. And once she explained that and she did that, it provided that bereaved parent with some sense of comfort and a different way of communicating in an environment where it can be so tricky. We also have heard about just how difficult it has been to take in the messages, the medical information that's required when you've just been told that your baby's died. And this has been, I guess, the fact that so many people are turning up for these appointments on their own has made that even more difficult. One bereaved mum said that she couldn't take it in and that she was all by herself because her husband was having to stay home to look after the kids because there was no school. And the thing that she appreciated most was the call that was made to her and her husband afterwards, because she knew she didn't have all the information to answer his questions because she just hadn't been able to take it in. And so those small acts of follow-up are also proving to be incredibly important. You'll see again that this result has been very positive and that in fact people certainly have experienced improvement in communication during this period. When we asked about if people felt they had the information they needed to make decisions about their care, the results were largely the same as they'd been previously. I think it's important though that we do understand that this is just a perception and it may not be the reality. Certainly within the survey, several parents acknowledged that there might not have been any more information that the medical professionals held, but that they certainly still didn't feel like they had enough to make the decisions that they were faced with. On a positive note, there was another story about a bereaved parent who's, after the birth, was advocating very strongly that she just wanted to go home. She didn't want to be in the hospital. She couldn't have the people around her that she wanted to care for her. And a midwife sat down with her and actually said that a cuddle cot was available and explained, I guess, the implications for that in being able to spend more time with her baby. And whilst the midwife didn't make the decision for the couple, she provided them enough information for them to decide to stay a little longer. And those parents were hugely grateful for that additional time that they got to spend with their baby. So I think these positive stories and these examples also help us to understand that there are ways and means of providing good bereavement care from a parent perspective, despite the COVID-19 restrictions. When asked about opportunities to ask questions about either your own care or what would happen to your baby, whilst the result was very positive, the examples that where the experience hadn't been so good are the kind of things that haunt bereaved families. One bereaved mum talked about the nightmares that she had thinking about her baby being down in the morgue. And while she knew that it was silly, the narrative and the thoughts that she had became the reality for her, whereas having asked questions about that earlier on and having things explained could have made a significant difference. We also had a bereaved parent ring our support line and talk about how distressed she was, that she'd agreed to an autopsy, but she'd thought that she would still be able to have the remains that she wanted to bury on country of her baby, and it didn't turn out to be that way. So again, I think it's just generally showing that the communication aspects of bereavement care are the things that can either make it an easier journey or significantly complicate it down the track. When asked if medical professionals acknowledge you as parents, one of the best stories that I had, again, came from a woman who said that when she birthed her baby, her obstetrician had said, "Oh my goodness, he has his mother's chin, but he's long just like his dad." They were the first words that this mum heard when her baby was born. And she said that it was one of her most precious memories because so few people had seen her baby. And that is significantly different during these COVID-19 times. Didn't take anything for that obstetrician to make those observations. They might not even have been true, but they've helped that bereaved parent form a narrative about her child that she wouldn't have otherwise had. Sadly though, not all the results have gone in the right direction. And this is one of the areas where there's been a small but disappointing reduction in the way that bereaved parents have perceived the bereavement care that they got. We all know how absolutely critical memory making has been and is, that bereaved parents have such a tiny window to create a lifetime's worth of memories. On a positive note, one bereaved parent told us about a midwife who told her to call the grandparents and ask the grandparents to each choose an outfit that they would like their baby to be to wear and to be photographed in. And so the grandparents went and they chose those outfits, and those outfits were left in a place where the midwife could pick them up. And in fact, the midwife supported that bereaved mother to clothe those babies and take those photos, creating memories for both the grandparents, but also for that mum in terms of feeling like she was sharing the experience with more than just herself. Another midwife helped a family surround their baby with love. That's how the mum described it to me. And what she did was encourage family and friends, or encourage the bereaved parents to ask family and friends to send a photo of them, and they pinned them up all inside or taped them all up inside the cuddle cot and then took a photo. So that baby was surrounded by all of the people who did love and care for them, even if they didn't get the opportunity to meet him. Also concerning was that the supports to other family members, including children, wasn't discussed with bereaved parents. And it seems that there might be a little out of sight, out of mind approach going on. Whilst the care directly for the bereaved parents has been quite good, the broader circle isn't necessarily being thought about in quite the same way. That being said, there have been so many FaceTime calls, so many visits through windows, so many medical professionals who've taken the opportunity to do the best that they can to connect family with these lost babies, whether that is by babies going home or through other methods. But in particular, we know that recognition of grandparents and those key females in a mother's life are absolutely critical for a good grieving processes. So providing them ongoing support is actually really important if we're going to make sure that that bereaved family has the community supports around them that they're so likely to need. It was also disappointing to see that providing information about community support services had reduced. In the 9 months before, we'd made some real inroads on that one. And again, we know that whilst hospitals are a great source of referrals to organisations like SANS, family and friends recommendations or referrals and online searches still make up the same amount of referrals as come directly from hospitals. And I think that's something that we can certainly improve on. When we asked one bereaved mum how she found out about SANS, she said to us that the midwife had put the number directly into her phone, and the midwife had said to her, "You might not need this. I think you probably will, and I want you to have it at hand when the time is right." And I thought that that was such a great way of doing it, because very often bereaved parents tell us that they don't remember receiving brochures and they don't remember hearing about organisations like SANS that can provide support. So doing something like putting a number in a phone, I thought was a really interesting way of addressing that difficulty. The survey also asked some questions or also gathered some information around pregnancy after loss. And this wasn't because we asked a particular question, although I guess the questions we were asking around it led to this particular topic coming up throughout the commentary. So it's definitely viewed as being even more difficult in the current circumstances, and the retelling of their story and the poor continuity of care was increasing the fear that parents were experiencing. High-risk clinics were hugely valued, and I think that we all wish that they were available to all bereaved parents. So that's certainly an area that, you know, we'll need to continue to advocate heavily for. One thing that did become really clear, though, was that referrals to community supporter organisations can be made to support for pregnancy after loss, not just at the time of loss. And that peer support in particular, although counselling as well, can be very helpful in helping alleviate the anxiety that parents face when they tackle pregnancy all over again. And finally, and very disappointingly, was that anxiety is leading to more than 30% of parents with previous experience of pregnancy using home Dopplers, which is obviously a circumstance that is very worrying, given that we know that home Dopplers can't be used can't be used appropriately without good training, and that parents can so easily misunderstand what it is that they, or the results that they are seeing on home Dopplers. So there's certainly more work that we need to do within this space to support for pregnancy after loss, and COVID-19 again is exacerbating that experience. Finally, I want to say that it's an absolute privilege to represent the voice of bereaved parents in sharing this information with you. The stories that they've told allow us to ensure that bereavement care continues to evolve and that we continue to meet their needs for the future. So thanks everybody. That's all I've got for today, but I'd be happy to answer any questions.
Fantastic. Thank you so much, Jackie. So we have a few questions here already, so we might start with some of these. And there's some direct questions for you, Jackie, about the service. So the first one is from Joanne, and she has said, what can I tell parents about what happens when they engage with SANS? Can you take me through the journey they will take after they have contacted you?
Absolutely. So the beautiful thing about SANS is the minute that they dial our 1300 number, the person who answers the phone is a bereaved parent, and that person is the person who will provide them with the support that they need there and then in that moment. So in that crisis point, wherever it is they call, there is nothing else that they need to do. Some parents don't even choose to share their own names, and it will be completely up to them as to what information they want to share and how what are the support that they want. If they're seeking counselling through Red Nose, they'll obviously need some more details to connect them up to the right type of counsellor. And you can call either SANS 1300 line or the Red Nose 1300 line and access both services. The other thing though about SANS is that we know that talking about it isn't right for everybody. And so one of the things that's happened over the course of this COVID-19 is that we have moved so many opportunities into community opportunities for bereaved families to engage with our community online. So there's a book club, and one of the people who came along to the book club in the very first instance said she wasn't ready to talk about it, but she just wanted to be able to sit with some other bereaved parents. And so that was the way that she chose to do it. There's journaling groups, there's coffee catch-ups, and in fact, there's even been community play dates for siblings so that we've brought groups of siblings together. So kids don't feel like they're alone in this journey either. So certainly if you go onto the SANS website, you'll find lots of different opportunities. And we think that there's probably something for everybody at the moment.
So Jackie, that might just take us on to the next one, and then I'm going to direct a question to Fran. But from Daryl, it's a question around how often would a bereaved parent go and get through to a peer supporter rather than a trained counsellor when they contact SANS?
Okay, so if you're contacting SANS directly, you always come to a peer supporter. That is the model of care that we provide. Red Nose provide both peer support and counselling services. And frankly, I don't think we should get too caught up in worrying about what type of service is right. And certainly what we know is that bereaved parents very often don't know what they want at the beginning. So calling and talking through with somebody, you'll find that the peer supporter on the other end of the phone will help that person work out exactly what might be best for them, and will certainly recommend counselling if that's a course that makes sense for that particular person or for their family.
Okay.
Adrienne, I know that I've mentioned Red Nose and SANS together a couple of times, so I probably should just explain that these two organisations are in the process of merging at the moment. And in fact, COVID-19 is the thing that stopped that occurring quite so quickly. So that's why I guess I'm talking about both service sets. But the other thing about calling SANS is that if you need a referral to any other service, or if we know of face-to-face support groups or other services that are occurring in places we don't have them, we will absolutely connect parents up to whatever's available in their area.
Fantastic. So the next question I'm going to direct to Fran. So this is from Jane, and she's asked, as a midwife, I was wondering if the bereaved parents find that the bears of hope, the teddy bears that are given out in clinical settings, are helpful, as it's a practical thing that midwives can do, certainly during the pandemic as well as before.
Thanks, Adrienne, and thank you, Jane, for that question. I'm not sure that I have a direct answer, because I'm not sure that there's been any actual evaluation. But what I would say is that parents need support, and they need recognition of their baby, and they need options. And that's the most important thing of all. And Bears of Hope, the teddy bears, is a way of acknowledging, of recognising the baby, and that is something that will be a great thing for most parents. But what's particularly important is that parents are given options and they're asked what they need, what would be most helpful for them, rather than, for example, just, throwing a bag of what we think might be useful at parents, asking them what's going to be most helpful for them.
Adrienne, if I could just comment on that too. Fran's exactly right. One of the things bereaved parents tell us very often is that midwives and health professionals feel this profound need to try and help them, and that giving things can be a practical way of doing it, but if it's not what they want, then it's actually more about the midwife and than it is about the bereaved family. And what bereaved families want more than anything else is understanding. Now, those teddies can be absolutely touching to some people, but as I said in the example, where one was placed in a coffin and that wasn't a Bears of Hope teddy, it was something completely different, but that wasn't what that bereaved family wanted.
Yes, absolutely. So I guess actually for either of you, there are two related questions here. One is from Lily about tips or ideas for including and involving siblings. And then from Gavin from Heartfelt around creative memory making. And is there a collection of those ideas anywhere that can help clinicians, and any other photographic ideas that Heartfelt may be able to help with?
Oh, look, Heartfelt are an absolutely amazing organisation, and bereaved parents all across Australia, I think, love Gavin and his team. And certainly what they've done during COVID-19 in terms of putting themselves at risk to provide memory making for families has been absolutely amazing. SANS has several brochures around creating memories. One is associated with where you can have access to your baby, and one is where you can't. And they go through a number of options and opportunities for memory making in all of its different and varied forms. I think the thing about memory making, there's two components to it, isn't there? There is the actual memories. So bathing your baby, dressing your baby, holding your baby are things that leave an imprint on your heart and in your head. And then there are the keepsakes and creating those things that you can look back on. And both of them are really important in this journey. And I think the thing about memory making is that there is some of it that is absolutely time critical, and then there are things that you can continue to do over time. We had a go at crafternoons, and in fact what we found was that it was pretty scary for most people because the majority of us don't consider ourselves to be very creative at all. So we're having a look at how we go back to that, but we certainly know that there are huge opportunities for art therapy type of responses to help support bereaved parents.
Marvellous. So I think what the last question we might address was to Fran from Nicole. You mentioned compassion fatigue needs to be monitored amongst providers, but at the same time training's been suspended during the pandemic. How can this be addressed?
Yeah, look, that's a great question, Nicole, because yes, at this time we have the double edged sword of no training and higher levels of risk. So yeah, we do need to think about some new ways of making sure that providers are getting the support and training that they need. The obvious way, I guess, is for us to provide some training online, and I know there are a number of options for clinicians and others. And I know that in some settings there have been some less formal kinds of, peer support kinds of activities that have taken place in response to the current situation. But, I'm not sure that there's, anything kind of formalized, and it would be great to see a more coordinated approach to provide and evaluate the training. And once again, I just mentioned the improved training, which is available online.
Okay, so I think I'm probably heading towards the end now. We're at 18:28, but there is a question from Claudia Rivaldi, who has joined us from Italy, and she has said, in Italy, we noticed that subsequent pregnancies are particularly challenging, and Jackie's already mentioned that from the SANS survey, particularly for limitations of the partner's presence at the birth, and that's obviously different in different countries and different settings in the same country. But do either of you have any comments, suggestions, or experiences on this particular issue, subsequent pregnancy and experience and partner involvement?
So we certainly, I guess, we're unaware of, nobody's complaining to us that their partners haven't been present at all in Australia thus far, but there are so many fears about that. And in fact, the anxiety around what is going to happen, I think, is probably what we need to be managing most closely in Australia currently.
Yeah, okay, great. And I guess a shout out again to that Global Cocoon project, which is trying to collect this sort of information across the world, which is a great thing. Okay, so just a reminder of those SANS and Red Nose and Bears of Hope numbers where support can be sought and is available. And we are bang on time, 18:29. I've got 1 minute to tell you about the next webinar. So next week, we're going to hear around timing of birth. What do women want to know? What should they know? And how do they want to receive it? How should that information be discussed to allow for shared decision making? So thank you very, very much for your attendance today. We hope we should have the recording ready by Tuesday or Wednesday next week, and you'll receive an email so that you can download that recorded webinar. And thank you very much again to our presenters, Jackie and Fran, and a huge thank you to my co-chair, Anne-Marie, for telling your personal story. Thank you.